as she said, is combination treatment or intensification treatment, if you will. How to select? Of course, we have to pay attention to patient characteristics, patient preferences, but also tumor characteristics. Concurrent mutations, TP53 is a very a specific marker of a non that favorable evolution with OSI alone, but also location of metastatic disease, liver and brain are relevant for making decisions. Of course, other comorbidities are also important. If we have a patient with renal impairment, for example, we know chemotherapy, platinum-based chemotherapy might not be the best option possible for that patient first line. And of course, try to offer your patient the best option first, not try to keep it for the next line, because a significant proportion of those patients never make it to the second line.
Perfect. So Shahina, my question is that you clarified totally that how we are selecting, especially if we do have the two options now. So still our concern that 2 points. The first, that if we start with amivantamab lazertinib, the subsequent line, the patient will not be exposed to osimertinib as one of the elements because we already used the lazertinib. And the second element, that the toxicity profile, and you clarified again that you involved. So the point is, in the point of the toxicity and also the conventional treatment, and it's almost the same, still we do have some barriers to choose the lazertinib plus amivantamab.
So I think the first point of what we can use in the second line, I think that if you're using lazertinib, you don't need to think about using, osimertinib later on, because efficacy is the same. And we saw that in Mariposa 2. And we're seeing some upcoming studies, and you can correct me, Professor Ignacio, because you're the expert here. There are trials actually looking at the combination of osimertinib with amivantamab, and there's been some small anecdotal studies that have actually shown that efficacy is probably the same. So I think that part is gone. You've given your EGFR TKI, you've given your amivantamab. What you use in the second line setting is now going to be your chemotherapy, either an ADC or just pemetrexed carboplatin. I think, that would be the standard of care at this point in time. I think the real question for me is, where do you place the ADC? We have Dato-DXd, we have SAC-TMT, but none of those trials actually used combination treatment in the first line setting. So what are we going to do, and when are we going to do it, and whether the effectiveness is going to be the same is the question I'm asking a lot of the time. But I do know with clarity, whether I use osimertinib chemo or I use lazertinib amivantamab in that first line setting, it's imperative that you do it, because you're getting the biggest bang for your buck in terms of getting those patients to be in long-term remission, and there's an overall survival advantage. Should we be scared of the side effects associated with amivantamab, lazertinib? I think absolutely not. Like any new therapy, you learn how to manage it. Initially, yes, I was freaked out by the infusion-related reaction because my first patient had it, and I very quickly learned that there are protocols that you put in place, and with Skipper and Cocoon, you learn how to do it. And I haven't had any infusion-related reactions since then. And this particular lady, and I have currently 4 patients on amivantamab-based protocol, and I can tell you their side effects are so manageable. One, you do judicious use of those antibiotics and skin creams, which, by the way, you need to use for any TKI. Second, you do DVT prophylaxis. And third, you have the infusion-related protocols in place. These patients do so well. I can show you a picture of a man who's on amivantamab lazertinib. He sent me a picture of himself playing golf. I was freaked out because it's so hot in Dubai. I said, don't stand outside in the sun, you get more acne. But he's having fun with life. So it's not as bad as people think it is. It's our mentality of how to learn. It's a new drug. We need to learn how to do the side effect management. Osimertinib and chemotherapy is also a good option, but do not think that it has no side effects. There are also side effects associated with it. And one of the most common problems that I'm seeing in the community is the misperception that you start Aussie plus chemo and after 4 cycles you drop all the chemo and only continue on osimertinib, which is not true. You're supposed to drop the carboplatin and continue the pemetrexate, which also has toxicity but improves the PFS. Learning to manage by dose reduction is also important. So in my mind, I think it's just a question of managing. They simply have to get combination.
Perfect, Shahina. So last comment by Professor Ignacio, so we can just go for the agenda.
Yeah, so I completely agree. Just one comment regarding the second line options. I think, as she mentioned, ADCs are one option. Just platinum-based chemotherapy would be another option. But I would not forget the option of combining chemotherapy with anti-VEGF strategies, or even Harmony trial with ivonescimab.
Yes,
probably another option.
yes.
Perfect. Thank you, Dr. Shahina. I know that you have to run for commitment, and I would like to thank you again. See you shortly, inshallah. Thank you.
Thank you. Take care. Bye. 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 Bye.
So we'll go for our next speaker, Dr. Osama Halawa. Dr. Osama is medical oncology consultant in Johns Hopkins, Saudi Arabia. He will share one of his cases as well, and he gave us his experience about using this medications as well. And with no further ado, Dr. Osama, the floor is yours.
Thank you very much for inviting me today. Thank you, Dr. Merva. Thank you, everybody. I have actually 2 quick cases, and we'll probably have more questions about the second case. So let me just move with the. So, you know, for people who are old enough to remember, the classification of lung cancer was adenocarcinoma, squamous, and other. And then we started seeing a plethora of mutations. And with time, we started to have target for each of these mutations. And to zoom in for the EGFR mutation, there are the classical EGFR mutations and the uncommon EGFR mutations. And of course, today we are talking about the classical EGFR mutations. In 2003, I started my fellowship in oncology, and I started hearing the word gefitinib and Tarceva. Tarceva is erlotinib, gefitinib is an Iressa. And they were used in all comers with lung cancer. We did not know which patient will benefit and what's not. And gradually we started to know that these patients are only beneficial in the patients with who harbor the mutation. So we are lucky now, in a way, to have all these medications on top of the timeline that can be used in this particular mutation, when we 20 years ago had nothing but carboplatin and Taxol or carboalimta. So having choices is always a good thing. So I have 2 cases. One is a straightforward, and the second one is a little bit challenging. The first case is similar to the case that was presented by Dr. Shahina, 58-year-old lady, never smoker, presented with picture stage 4 adenocarcinoma of the lung, multi-organ burden, including brain, bone, and nodes. And the patient had also MET co-driver and PD-L1 positivity. So again, the patient is a 58-year-old, never smoker, no prior medical problems, excellent functional status, progressive back pain, radiating to the right leg with no neurological deficit. The imaging study revealed that she has right lower lobe lung mass with confluent mediastinal nodes, and imaging studies revealed that she also has widespread lytic bone lesions, and she had multiple brain lesions, although she was having no symptoms from the brain metastasis. The biology of the tumor, after doing the NGS, she was found to have EGFR exon 19 deletion, and the immunohistochemical staining revealed that she has MET amplification. Of course, the PD-L1 was positive, which is not uncommon to be positive in patients with the EGFR mutation, and this need to be ignored in a way and not think that this patient is going to be immune sensitive. And in fact, giving the immune therapy by mistake could harm the patient subsequently if given anti-EGFR treatment. So the patient had 3 or 4 high-risk features. The patient had widespread metastatic disease. She also had brain metastasis, and she had also the MET amplification. Again, I mentioned the PD-L1, it's expressed and it is high, but it does not mean that we can use immune therapy in this case because PD-L1 does not predict immune therapy benefit in EGFR positive disease, and TKI or bispecific antibodies with TKIs are the standard of care. So again, the mechanisms, or the points that were addressed in this patient, we had a MET co-driver who was addressed by giving the amivantamab, and this was the case in this patient. Again, the patient had high-risk features, and we picked the agent or the treatment choice that will give us the highest PFS with these high-risk features. And as we know, CNS penetration with lazertinib is significantly therapeutic and proven to be effective in this case. So we opted not to give local therapy to the brain and start with the systemic therapy. And as we all know that the MET amplification is a resistant pathway in using EGFR TKI only, and this was addressed early on with the use of amivantamab and lazertinib. The patient had early imaging, and we have seen that she has responded by imaging studies. And the patient, of course, as mentioned in the earlier presentation, had prophylactic measures to prevent allergic reaction with the IV administration. And we hope to see the subcutaneous formulation available in our clinics very, very soon. And I expect this to be in the next 3 to 4 weeks. The patient had denosumab. The patient had prophylactic, anticoagulation because of the risk of thromboembolic events. And again, with the sub-Q administration, I'm sure the speakers will be talking about this. With the sub-Q administration, this is significantly less. And the patient had re-imaging of the brain, and this showed that she had also partial response in the brain with no neurological symptoms still. This is the timeline of the patient, and we can see that she was diagnosed in 2025, and we can see the patient continues to be in therapy. First cycle was started in January 15, and the patient continues to be in therapy now for almost 6 months. So this is a straightforward case treated with the best standard of care available, but I have another case where we have to scratch our head and think of what's happening. So this is an 80-some-year-old. He had AFib, but the normal ejection fraction, 55%, presented with left-sided chest pain, and PET scan showed that he has left upper lobe primary with metastatic left hilar node and nodular lung opacities, and he had FDG avid sclerotic bone lesions in the left iliac wing and right scapula. The biopsy showed adenocarcinoma, acinar predominant, consistent with lung primary. He has some pleural fluid that was also positive for malignant cells, and the brain MRI showed small left frontal basal enhancement concerning for metastatic disease. The NGS revealed that the patient has exon 21 L858R. So again, this is to summarize the case. In July 2025, widespread metastatic disease, small brain lesion, left lung with pleural effusion, and he has symptoms with left-sided chest pain, and he also had bone metastasis. So again, to summarize, the lung biopsy showed that he has the EGFR exon 21 mutation. So what do we do? Again, he's an 80-year-old man, AFib, and we decided to go with the gentler regimens, and we decided to go with osimertinib. And in August 2025, he started an osimertinib, And he had actually PET done in November, which showed favorable partial response to therapy, but clinically he was much better. Patient was kept in the same treatment, and then he started to have worsening pleural effusion. And as part of the workup for the pleural effusion, we did echocardiogram. And the echocardiogram showed that he has a drop in ejection fraction from 55 to 25%. And honestly, I've given osimertinib very frequently over the past many years, and I have never seen cardiomyopathy related to osimertinib. And I did literature search, and it does do cross-talking with the HER2 pathway, and it does cause cardiomyopathy reported in up to 3 or 4% of cases. So I tried to give the patient a break and see if his ejection fraction is going to improve with holding the osimertinib so I can re-challenge it. And it did not improve significantly enough where I can restart. So I was closely monitoring his disease. And in April 2026, I did imaging studies which showed that he has progressive disease off therapy since March. And at that point, I could not wait without systemic therapy. So I decided to go with amivantamab lazertinib. So the PET-CT scan in April showed that he has progression in the lung nodules, and he has also reactivation of the sclerotic bone lesions. So again, toxicity forced me to pause the treatment, and the plan must adapt. So the toxicity can drive treatment dimension as much as efficacy. And we know this being oncologists that we do a lot of dose adjustment and drug holidays or drug stopping because of toxicities. So I did not do rebiopsy, but I sent the pleural fluid again for cytology, and it was positive. Okay, but I would insist on doing biopsy if the patient has progressed on treatment, but this patient progressed while he's off treatment that was stopped because of toxicity. So progression of therapy does not necessarily equal acquired drug resistance. Of course, the cardiologist and the cardio-oncology input was concurrently co-managing the patient with me, and the decision ultimately with the cardiology that we cannot start osimertinib again. So the patient was started almost 6 or 8 weeks ago in amivantamab and lazertinib, again, because he did not progress in osimertinib, and he clinically has done very well, and he started to have subjective improvement in his well-being. So these are the two cases, and I really appreciate your feedback and your input in my cases.
Thank you very much, Dr. Osama, for sharing your two cases. It's very inspiring, and I think that, like you said, the second case, it was very challenging, especially the patient who have the two elements that the patient has toxicity. Myself, I saw actually it's infrequent, like you mentioned, regarding osimertinib and cardiac toxicity. I saw it's totally uncommon. But I saw in 1 or 2 patients dropping, but it was not that significant like your patient. And the second element that the patient has toxicity, and in the meantime, patient became refractory as well. So, Prof. Gilbazzo, in such cases, do you think that we need to go for amivantamab lazertinib, or we have to go for amivantamab plus chemotherapy? We know that the patient is almost 80, if I still remember right.
Correct.
So we have to go light on those patients. So we do have now clearly that the patient initial response and then the patient progress. And kindly, Dr. Osama, he is doing great that he looking at the biological element as well regarding if we do have any refractory issues. So putting this together, what is the choices for us for such cases? What do you think, Prof. Gilbazzo?
So I think when we can actually diagnose a patient with MET amplification de novo, before any first-line treatment, which is the first case he just presented. I think for those patients, it is really difficult for us to decide whether to go for something else or different from AMI laser, because we are actually targeting not only the primary target that would be EGFR, but the secondary, very importantly in this case, target, which is MET, which is at the same time another emerging mechanism of resistance that the most typical for osimertinib alone. So treating this patient with osi alone probably will not render very good results. And of course, we have to consider the toxicity, the expected toxicity profile, and we can mitigate it very well with the different Cocoon, Paloma-3, skipper trials. And of course, if we have, or if you have the option, which is going to be very, very soon, as you mentioned, of providing this patient with the sub-Q formulation, I think I would really encourage you to do so. My experience with the sub-Q formulation is really, really good, and no more infusion-related reactions and minor or non-administration-related reactions, which is what we may have potentially with the sub-Q formulation.
Perfect. So the point is for the patient, who, how frequent you have patient coming with the toxicity profile, cardiac toxicity with osimertinib plus Gilvazo? How frequent you have?
I think probably we do not thoroughly follow the patient and monitor the patient for cardiac function. So that would be my first message here. I think we proactively have to look for that at onset and then during the treatment. That is something that we should do for sure. And in my practice, it's less than 5 to 10% that we can actually see there is a drop in the cardiac function or the left ventricle function. But the problem is it can be really severe, and that is something that. And I'm just remembering one patient that died because of that, especially for elderly patients, in which osimertinib has been a very good option for a long time, monotherapy. But still, these patients sometimes already have a cardiac issue, and this could be, worsening the situation.
Yes, correct. So, Dr. Osama, how about the toxicity profile? You have experience with 2 patients, and you know that we start to exposed to this regimen. I think we still have some concerns regarding the toxicity profile, skin manifestations, and also the infusion reaction. In your 2 cases, how do you see that starting from the infusion reaction, putting this together with the DVT and also the skin manifestations?
With the proper introduction of proactive measures, I think these things can be mitigated quite significantly. And what I mean by the proactive measures with the infusion, first cycle, you have to give day 1 and day 2, split the dose and pre-medicate with decadron for 3 days prior, and diphenhydramine. And also with the topical agents and the oral antibiotics, that helps quite significantly. You could still see some paronychia sometimes, but again, it's not as bad as we were concerned about before we started using the medications. And to be honest with you, infection and thromboembolic events are the top 2 killers in cancer patients. So and we know, like, if we do the corona score, a significant number of our patients will be eligible for prophylactic anticoagulation. So I don't see a big issue with giving the patients prophylactic anticoagulation, even beyond the first 4 months, because if they're not having bleeding symptoms and they're tolerating the treatment just fine, I might extend it even longer than that.
Perfect. I think Prof. Gilbazo here is a very good point, and also you, Dr. Osama, that because your patient was MET positive, and we know that the dual factors regarding amivantamab is EGFR and as a dual inhibitor. So do you think that if you do have any patient who's coming, or we are doing for them the NGS, and we found that the patient EGFR positive and MET positive, we should go for amivantamab plus lazertinib as an upfront, or we still have a space for the osimertinib plus chemotherapy?
I think the patients has to be stratified in the beginning, whether they have MET amplifications or not. And if they do have MET amplifications, like Dr. Gilbazo said, I think these are not expected to do as well with the osimertinib or TKI alone. And I think I don't want to like use big words such as inferior, probably going to be inferior, but we don't have randomized trials. But we know that we have to target both. And we know that the prevalence of MET amplification after osimertinib is significantly higher as an escape mechanism and resistant mechanism. So I think all patients with the EGFR mutation have to be stratified according to the MET and treated accordingly.
Yeah, but Prof. Gilbazo, when we look at the subgroup and also the biological effect of amivantamab plus lazertinib, we found that there is inhibition of the MET, but it's not totally mitigated or suppression totally. Still, there are inhibiting and less. It's about comparable to the patient who is receiving osimertinib. This doesn't mean that so it has some effect, but it's not totally inhibiting. You got the point? What I'm
Yes, I
saying,
do.
that this combination just give partial inhibition. It's not complete.
Yes, definitely. I think, again, MET can be amplified. It can also be mutated at the same time. And there might be different alterations. So, I think, probably considering that we are going to be able to block MET completely, that's not possible in most of the cases, but probably sufficient for controlling the disease in a longer period as we normally see.
Yes, I agree totally. Perfect. So we'll go for, thank you very much, Dr. Osama, for sharing your case. Please stay with us for, we do have cases, we need your opinion as well. So we'll go for our next speaker, Dr. Dua bin Jabal. Dr. Dua, she is a medical oncology consultant and IMC in Jeddah, and she will share one of her cases as well. Dr. Dua, thank you very much for joining tonight, and the floor is yours.
Thank you, Dr. Mirvet, for the introduction and the invitations. So I was also asked to share one of my patients on Mariposa trial. So I think you can see my slide now.
Yes, we can see it now, please.
So I have again this patient is similar to the previous two patients. She's a 58-year-old female patient who is medically free before, non-smoker. She has not significant family history, lymphoma and breast cancer, which is not related to lung cancer. She presented with a 1 to 2 year history of back pain, worsening recently before the presentation. She had an outside MRI, which showed multiple bony lesion, which required further investigation. So eventually she had a CT and PET scan, which showed a right lower lobe mass with multiple hilar mediastinal lymph node and widespread bone metastasis. She also has a brain MRI, which showed multiple intracranial and osseous metastatic lesions. She had a bronchoscopy, failed initially, or the sample was insufficient, does not fail, and then underwent CT-guided biopsy, which showed an invasive lung adenocarcinoma, and then we sent for molecular testing. So she received her whole brain radiation while we're waiting for the molecular testing. and it came as EGFR mutation exon 19, and also she has an MET amplification. These are the other findings in her molecular testing. So, and then we had our tumor burden discussion, which way we want to go with this patient. We have the FLAURA1 with osimertinib alone, and we have the osimertinib and chemotherapy as a FLAURA2, and also have MARIPOSA with amivantamab and lazertinib. And because of the mutation and MET amplification, we decided to go for MARIPOSA trial. So, of course, like start using the regimen for the first time, we are concerning regarding the infusion-related reaction, which was really significant, 67% the incidence in the cycle 1, and also higher incidence of dermatological toxicity as well as the venous thromboembolism. And to minimize the incidence of these toxicity, I went through the skipper, COCON, and VTE protocol. So the skipper is primarily for the infusion-related reactions, the COCON for the skin toxicity, and then the VTE guidelines to give the primary prophylaxis with anticoagulation. So the skipper, basically, we give the dexamethasone for 48 hours prior the infusion day. So patient started on 8 milligram BID a day 2 before the treatment for 2 days, and then on the same day in the morning she had to receive also 2 tablets, like 8 milligram. So total of 5 doses before the infusion, and then the infusion day gave her as well IV dexamethasone, antihistamine, and antibiotic. And also the first infusion has to be on split 2 days to minimize the risk of the reactions. And this has been shown that the incidence of reaction dropped from 67 to 22% using the skipper protocol, with confirmed the activity of the medication. The second way to go is using the COCON protocol for the dermatological toxicity, which include the face and body, scalp, and nail. So I add for her the doxycycline 100 milligram BID, and it has to be for the first 3 months of the treatment. And then ceramide-based moisturizing, SPF 30 as well for the sunlight protections. And for the scalp, the clindamycin solution, typically you have to start it in week 12 or 13, because here where the time of the scalp lesions occur. And for the nail, to decrease the Bernoulli, we have to use the chlorhexidine 4%. As a continuous throughout the treatments. And using the COCON showed that a total grade 2 and more decrease from 75% as compared to 42, and also the facial toxicity decrease. Bernoulli actually is similar, however, we'll come to this when I'll tell you about the side effects with my patient. And then the VTA risk, the incidence is 37%, and it's mainly in the first 6 months of the treatments. And in the PALOMA-3 trials, actually this trial for the subcutaneous regimen, however, for patients receive a VTE prophylaxis, the incidence of thromboembolic event dropped to 7%. And we can use either the low molecular weight heparin or even the direct oral DOAC. Okay. So back to my patient. In December 25, she received the whole brain radiation as for the brain metastasis. And then January 14, we admit her for the first treatment. She received the split dose in day 1 and day 2, along with lazertinib. And then also she received denosumab as a bone supportive agents. And also we started her in VTE prophylaxis with enoxaparin 40 milligram. So as regard of this toxicity, actually she tolerated the treatment well. There was no infusion reaction with the first inductions 4 weeks of the treatment, and also during the further maintenance treatment. She had only grade 1 vesicular rash on the lower lip, seen by dermatologist and resolved. And also she has paranoia in March 18, which was also treated effectively. And in February, she has been presented with a shortness of breath. We did the CTBE to rule out pulmonary embolism. This was happened after 1 month of the treatment, and we can see her, the primary lesion actually showed some response to the treatment. She continued with the treatment without significant toxicities. And then recently we did the PET scan for her for re-evaluation. So the picture in the left, it's the one with before the treatment, and the right after the treatment. We can see remarkable response with regression of the primary lesion as well as the bony metastatic lesion. So I've seen her last week. She's doing well. There's no current skin toxicities. She successfully completed her cycle 9 maintenance, and we plan to continue a follow-up with imaging for her. So in the summary, just doing a comprehensive molecular profiling, identify the dual target DXN19 and MET amplifications. This guide us in using a specific protocol for this patient, and proactive measurement always decrease the development of side effects and help the patient to tolerate the treatment with excellent quality of life. By this, I'll conclude. Thank you.
Thank you very much, Dr. Dua, for sharing your case, and congratulations for managing the patient very well. And I think you made it clear for the patient who have MET amplification, we may go for amivantamab lazertinib as an upfront, and I think the patient responding very well. Thank you, Prof. Christian Grow, for joining tonight. Prof. Christian Grow is professor of medical oncology, and he is one of the key leaders in lung cancer in Germany and in Europe. Thank you, Prof. Grow, for joining. Please go ahead.
Yeah, thank you so much. This was an excellent presentation. I have a question regarding, the family history is very remarkable. There's a brother and the whole family obviously affected with different kind of tumor entities. Is that maybe another reason to think about hitting hard and very effectively in terms of the treatment of that patient? Or do we have any data? There's no real risk factor history for her. What we have to consider, is there some kind of germline infection in the EGFR mutated lung cancer? We don't really know anything at all. So that might be something very well to follow, and just like to get to registries, as I pointed out earlier on. It's just, especially with the family history, very important. This has to be, especially in the follow-up kind of controls of these patients, that's going to be an issue in the next years to come. High-risk patient. So congratulations, nice presentation.
Thank you.
Yes, I think you raise a very good point, Prof. Grow, that for a patient with family history, we have to look for genetic profiling. And actually, for our patient now, for any patient has a family history, we are sending them to genetic team. They make for them like mapping, and also the expectations for the whole family as well, especially for multiple sites of the disease. Like the case with Dr. Dua as well. And should be actually for all the patients. Of course, we do have the higher incidence. It's mainly for the GI and breast, but in the lung cancer, it's not that common. But I think the patient was presented by Dr. Adwa. He needs to be referred to genetic as well and his family. It's a very good point, yes.
Yeah, thank you for raising this point. Honestly, I didn't think about to send for genetic because it's not very common for lung cancer to be associated with genetic disease, but maybe it's good to think for about it and send for the patient.
Yeah, the reason I asked, we now do a more broader approach and we look for BRCA mutations in lung cancer, where we started because we have this in PARP inhibitors. And for some reason, we find a lot of male patients who have BRCA mutations, and you do have to have counseling for prostate cancer and things like that. And then we went back into our database and looked for patients who have EGFR mutated lung cancer and had a history of breast cancer. And there seems to be some kind of correlation for that too. In taking all the smoking kind of behavior out is still for the non-smoking females who later on in their life experience lung cancer. That's very fatalistic for them because they feel I did everything correctly, properly. So why should I have another cancer? So obviously there are some correlations we have to understand. So I think family history, good family history is always good to know, and maybe more counseling. Maybe we should all get into that kind of business anyway, not only the geneticist.
Do you think that BRCA in lung has an impact as well? We know that, of course, BRCA has an impact in breast cancer, in pancreatic and prostate.
Yeah.
Do you think it's the same in lung as well? Because in the lung now we are very expanding on the genetic elements. So do you think that BRCA has a role as well?
Well, I personally believe in BRCA it's just the tip of the iceberg to understand germline mutations. And it's not like in breast cancer, but maybe other just contributors may have another opinion about that. But we try to understand what kind of inheritance we have to understand for some kind of our patients.
Yes, I agree totally.
Especially for high-risk patients, yeah.
So Prof. Grow, do you think that so Dr. Adwa made it clear from the start when the patient is EGFR positive and MET amplification, and she put the three choices together: osimertinib plus chemotherapy, or lazertinib. And by MDT, they went for lazertinib. So do you think that once we have this co-mutations with EGFR, MET amplification or mutation, we have to go for the lazertinib as a standard of care, or you find that maybe osimertinib plus chemotherapy is still a choice? What do you think?
Yeah, I think having the dual also not say mutations because MET here is not mutated, it's amplification, but having the dual targets, it's worth to go with the Mariposa, the combinations, because usually this tumor will be an aggressive, and it's one of the mechanism for resistance to osimertinib is how it's the development of MET mutations. So I think having a young patient with extensive metastatic disease, it's worth to give the right treatment from the beginning and hit it hard from the beginning.
I agree totally. So Christian, do you think that if you do have a patient with dual or co-mutation, you will go for osimertinib plus chemotherapy or lazertinib plus AMI, patient with EGFR and MET, and we have the NGS for this patient? What do you think that you have this patient in your clinic?
Well, as you just discussed a little bit earlier on, especially with the co-mutation landscape, and we don't really know too much about it, especially in the MET amplified kind of business, I'll go to the combination. But your case presentation clearly showed, you are somewhat limited or restricted by the side effects. This requires close monitoring. And if this patient doesn't live right next to your outpatient clinic, sometimes this is very crucial. That's for our patients, sometimes they have to travel quite a distance and they end up in certain kind of emergency rooms. Nobody is familiar with that kind of side effects. So this is going to be an issue, but osimertinib mono in these patients, I don't think that's no recommendation anymore, especially in very elderly, frail patient population.
So if we are putting another scenario of the patient, because we still have this toxicity profile, and I think Dr. Ada, she managed very well. So what do you think that if the patient intolerance for the treatment, especially if we are able to go for the infusion reaction, it will be fine. However, the skin toxicity, sometimes for some patients, they may not tolerate. So the point is, if I do have patient responding to treatment, but still not tolerating the skin toxicity or intolerance, what is our choice on such cases?
So this is not off the record, but this is something I would like to comment. It's just we discussed it at ASCO, all those in our patients. We don't really know both for the IO drugs or the TKIs and immunotherapy if we always need the full dosage. We know this. Maybe we need a loading dose. Maybe we need an adopted dose for fragile, small, all elderly ladies. We don't really know. And I think this is, I think one of the most prominent kind of features we understand, globally speaking, maybe less is more. Yeah, and we can stretch it or boost it. I think there are options, it's just maybe for all what we are doing, it's a lot for our patients just in terms to tolerate this kind of drugs business. So yes, I think we should go for amivantamab plus lazertinib, but maybe 4 shots are enough for a patient. Or we just control her, see how the response rate is or the duration response. We have to learn that.
Yes.
That's my personal opinion. This is not just in the label sometimes,
Yeah,
but I personally
we start to learn from what we are seeing and exploring as well. So, Prof. Gilbaz, so if the patient we will not able to give anymore, we do have a discontinuation. What is our alternative for a patient with intolerance?
So you mean intolerance to amivantamab, for example?
Yeah, intolerance to amivantamab plus lazertinib, we give the treatment and the patient responding. However, there is intolerance regarding the toxicity. What is the alternative for such cases?
Right. So I think we should first try to, as you mentioned, discontinue temporarily the treatment, try to see whether we can optimize the control of the different symptoms the patient is having. And I think lowering down the dose is a very good option. And sometimes this is, especially for those patients that are, with over 80 kilograms, for example, but over the disease, they go down to 78, 75, 72. And, we should take that into account and try to modify the dose. And as Dr. Groh just mentioned, I think sometimes for patients that are frail, we can consider starting with lower doses and try to see whether we can accommodate the doses up in the future, depending on the PS of the patient, for example.
Perfect. Okay, thank you again, Dr. Dua. We'll go for the second part, which is the cases was sent to us by our attendees. I'm very pleased and I totally appreciate our colleagues who are sending us cases. We do have tonight almost 900 attending the session. Thank you very much for your trust, and we'll go for the cases, and I need the opinion for the whole group. You can see my slides. Dr. Ragad, you are with us?
Yes, doctor.
Perfect. So we'll go for the cases, and then we'll go for the post. So the cases, as I mentioned, by our colleagues from different regions. And the first case is from Jordan. 77 years old gentleman known to have a patient is the smoker, PPH, and he has residual dural EGFR on dorsal T5 and 6. Status post-embolization. This was almost 3 years ago, and the patient, he is known heavy smokers for 60 years. The patient performance ECOG1, he was diagnosed lung cancer adenocarcinoma, and he was presented to pulmonology with the shortness of breath, bone-guided biopsy showed adenocarcinoma. PET scan showed that the patient has interval development of high metabolic activity in the lung mass, and also multiple hilar lymph nodes, pretracheal, and the patient has active metastatic osseous lesion. So the findings are highly suggested of primary lung cancer with metastatic lung nodules, metastatic mediastinal hilar lymph nodes, and multiple metastatic osseous. Confirmation was tissue biopsy was carried out, and the patient also has multiple hepatic focal lesions. So the histopathology was carried out and poorly differentiated malignant neoplasm, and all blood work and kidney function tests and liver function tests were unremarkable. NGS showed that the patient EGFR positive exon 21 L858 deletion was P53 and the PDL1 30%. I think it was made clearly by Dr. Osama that not to be deceived by the PDL1 and should be on hold. So the patient PDL1 30%, and as a summary, metastatic non-small cell lung cancer, bone and liver, EGFR positive with co-mutation P53, and patient PS ECOG1. So we can start the polling. So what is the best approach for this patient? Osimertinib plus chemotherapy, amivantamab lazertinib, or osimertinib single agent. Dr. Abdulaziz from Jordan, he is asking about what is the best approach for the patient. Metastatic multiple sites, bone, liver, and brain. Bone, liver, and multiple lung lesions. EGFR positive exon 21 with co-mutation. Can you please vote? We'll give 30 seconds, please, Dr. Aragad, and then you can go for the voting. Can you show us the results, please? So 56% go for the FLAURA2, which is the majority of our colleagues voting for the osimertinib plus chemotherapy. Lazertinib is still in the table, about quarter, and the osimertinib 21%, they are showing that it's an option as well. So, Prof. Gilbez, what do you think about the voting, and which one you will vote yourself?
So I think when we consider patients with high risk or poor prognosis features, we should consider, of course, combination strategies as the best option possible. So I do agree with the majority of the audience regarding that combination strategy is the way to go. When it comes to deciding whether AMI laser or OSI plus chemo are the best options, I think probably the factor that we are missing is the conversation with the patient and the family. So I think that is, at least in my practice, a crucial aspect, and not always what you consider as a barrier for starting a new treatment or as a a limitation for starting new treatment is always the case for the patient. So it really depends on what the expectations of the treatment for the patients are regarding first outcomes, clinical outcomes. We know that even though the final analysis of the overall survival for Mariposa is not ready, and we don't have those data yet, we are expecting a more than 12-month improvement in the overall survival analysis as compared to osimertinib. But of course, on the other hand, we also have to consider the number of times the patient has to come to the hospital. So, if you don't have access to subcutaneous formulation, the infusion-related reactions, and the rest of the toxicity profile, which is, for some patients, chemotherapy is a barrier and they don't want to go for chemo. So if you need a chemo-free regimen, you really need to go for AMI laser. But on the other hand, for some patients, let's say the paronychia might be an important factor because they use their hands for work or for playing piano or whatever, and that's not acceptable. So that candid discussion with the patient is needed here, probably.
Perfect. Okay, so Dr. Abdulaziz, as the panel discussion for the case, the voting, it was mainly about the osimertinib plus chemotherapy as an upfront. Still, the option of lazertinib for the patient who wants the chemo-free regimen, and the decision for the case, if you allow us, for going for the FLAURA, or as an option for you as well, and if the patient disagree about the chemotherapy, lazertinib. Thank you. The second case is from Saudi Arabia. 66 years gentleman, performance epoch 2 to 3, diabetes mellitus, hypertension, and CKD. His non-cardiac patient and patient presented with massive pleural effusion, pericardial effusion, and hepatic focal lesion. Biopsy showed adenocarcinoma grade 3, PD-L1 10%, and the NGS red positive. Patient is on dialysis. And how to treat this patient? Dr. Muhammad Sahaibani from Tabuk. Please vote. Critical stage 4, how to manage? Selpercatinib, single agent, IO plus chemotherapy, chemotherapy alone, or best supportive care. Can you please vote? 10 seconds, and then you please, we can show the results.
Sure, doctor.
Perfect, thank you. You didn't put music again, right?
I need it.
Okay. So can you please, okay, so selpercatinib about 19%, the voting, and IO plus chemotherapy 60%, chemotherapy alone 13%, and best supportive care 8%, still an option as well with this performance status. So Prof. Grow, what do you think? Can you please vote which one you will go?
You know, this is a classical case where we do a lot of testing in patients who are critically ill. And this is very important to understand in terms of should we elaborate in terms of testing and optimizing treatment options in patients who have performance status 2 to 3 in the long run. You know, we're not talking about small cell lung cancer patient, new diagnosis patient who sometimes need to go into fast remission. This is a constantly very ill patient. So my first question would be, again, as Dr. Gil Blasso already pointed out, is talk to the patient what he wants. He's on constant dialysis. We should talk to the nephrologist to tell him what is, I think, the likely outcome within the next 12 months, just to get everything into perspective. He has massive pericardial and pleural effusions, and that's going to mix up with the option of selpercatinib. It's an oral drug, but you know, isn't that easy to handle sometimes, and you wash it out all the time. The next question, I wouldn't go for, just to be honest, we have no data of the combination of IO and chemo with our background here. So the only option would to talk to the patient, best supportive care or chemo alone, or radiation therapy in terms of understanding where the lesions are. So we are somewhat really limited, and the best palliative care data we have show clearly no treatment is also a treatment in terms of omitting toxicity profiles. So especially on patients who are on a constant dialysis, hemodialysis, you know, the outcome is very critical to understand what we're going to do good for these patients.
Yeah, great, Osam. But I think the point of the oral medications and the selpercatinib is actually it's very good as a toxicity profile. And but my concern is the edema. But however, most of the patient, and even with the dose reduction, still those patients that they have a durable response with selpercatinib. So I agree with you totally. We are between the selpercatinib or best supportive care. I will not in favor to go for definitely not IO plus chemotherapy, and the chemotherapy as well. I will not be in favor with patient with performance 2 to 3 fusion, precardial fusion, and CKD as well. Dr. Osama, what do you think? Can you please vote which one you will go? If you still with us. Dr. Osama? Okay.
I am with
So-
you, Dr. Mervat, and
so تفضل.
I could not vote in the
Yeah,
and
the faculty, they are able the vote only by the attendees.
Yes. Okay.
So yeah, this is why we are asking about your opinion. What do you
Yes,
think
sure.
that?
I agree with you. In a patient with a poor functional status, unless it's poor because of the cancer, I would not give chemotherapy. But if the patient functional status was good up until the diagnosis, I'll give the chemotherapy a chance to work. If the patient has the RET mutation, I'll definitely consider the use of silperectinib, although I did not have any patient with RET mutation yet.
Yeah, I do have actually 2 patients. It's a very nice medication and they have a durable response. We know that it's about 3 to 4% of the population, but overall, as it was a good experience that those patients, they are not suffering like other medication. Okay. So Dr. Muhammad, the committee decided that go for selpercatinib as single agent versus best supportive care for this patient. I hope this helps. Next patient from Kuwait, she's a 41 female patient diagnosed with a stage 4 hepatic focal lesion and bilateral lung nodules, adenocarcinoma. The biopsy showed adenocarcinoma EGFR positive L858R mutation and the PD-L1 20%. Patient received osimertinib single agent and patient refused chemotherapy for 8 months with partial response, then patient progressed. The biopsy confirmed no transformation and patient still positive for EGFR. She received AMI Alimta carboplatin with good tolerance and response for a year. Last scan showed multiple brain mets and bone deposit. However, other disease sites almost stable and mild progression. So the patient received whole brain irradiation and local therapy to tender areas. Liquid biopsy showed EGFR positive and no commutation or transformation. So we have a long history of patient receive osimertinib as an upfront, followed by amivantamab plus alimta carboplatin, and now the patient progress on ami alimta and pose how to manage this patient. EDCs, IO plus chemotherapy, taxane base, chemotherapy alone, best supportive care. Can you please vote? Results, please, Raghav. So the majority, 54%, they are in favor for IO plus chemotherapy, which is applicable. Chemotherapy alone, 14%, best supportive care, about 7%, and the ADCs, we don't have any experience with the ADCs for such cases, 25%. So, Prof. Gilbaz, what do you think? Which one you will vote?
Sorry. So the truth is that in most countries, we do not have access to ADCs so far. I do not have access to ADCs for non-small cell lung cancer yet. Probably that will change soon, but as today, I cannot use them. Chemo-IO is always an option for patients in this situation. Of course, what is the role of immunotherapy for patients with this profile? We don't really know, right? And
Yes.
And what about the combination with taxanes? Of course, with paclitaxel, we know that there is a clear role, but with docetaxel, we have no idea, right? You know, if the patient is in a good PS, I think combination strategies are always a good thing to consider, chemotherapy-based. But however, as I say, I'm not really sure. My best option would be to try to put this patient in a clinical trial if possible. I think that's always the best option in this situation. But of course, you might not have access to clinical trials and you have to make a decision. So then it really depends on whether you have accessibility to ADCs, which in that case would be probably the preferred option, or depending on the patient's preferences, or chemo-based treatment.
Which one of the ADCs do you recommend? I think the colleagues in Kuwait, they have more accessibility for such expensive medications. So because we wanted to give him a clear vision what to do. So I agree with you that I think the ADC is considered a good option for the patient who is refractory. So if we are choosing between the different trials, which one you can see or you can recommend at the time?
So datopotamab deruxtecan is the only one approved so far by the FDA. And of course, we have a fast track designation for sacituzumab tirumotecan also. So probably that would be probably available or at least approved in the near future. But as of today, I would go for datopotamab.
Yes, I agree totally. So, Dr. Jassim, for the patient, the committee in favor for ADCs as the patient is now progressing, and the other option, it can be chemotherapy as an option for such cases.
Dr. Mervet, can I say something quickly?
Absolutely. Yes,
You know,
please.
one thing I would add to this case is I understand that at progression, the circulating tumor cells were positive for EGFR, but I would definitely, especially that we're having areas that have responded, did not progress, and we have new areas of progression, I would consider image-guided biopsy to one of the lesions. I have seen few cases where we have small cell transformation, and this might take your treatment in a different direction, chemotherapy-wise, and even with more ADCs as well.
Yes, I agree with you totally. But the issue that sometimes the possibility to take a biopsy sometimes, but I think your point is absolutely valid, as the patient has hepatic focal lesion and bone as well, and so we can just have a biopsy. And the biopsy, it was for the transformation, especially for this aggressive, it will be changing the vision. We tried, I think he tried with liquid biopsy, but sometimes it is not, even with a high burden tumor, we didn't see significant results like this. I think it's a good point. Yes. Yes, go ahead.
It's a high-risk patient and a rapid progressor. So this is well taken. This is unusual, right? The combination, he didn't respond properly.
Yes. Okay. So I think we can give a chance for possible biopsy. Just make sure that we are not missing something. And in the meantime, the committee voted more for the ADCs if you do have an access for this. And still, the chemotherapy is an option for those patients just to slow down the disease. The committee agreed about this, or any of the members he needs to add anything? Okay, so we'll go for the last patient from Egypt. 52 male, he is a professor in university, occasional smoker. He diagnosed as stage 4 lung cancer, bilateral lung nodules, and PET scan showed the thyroid mass, and biopsy from the thyroid showed the metastatic adenocarcinoma, TTF1 positive, and CK7 as well. The thyroglobulin is 72. We know that the normal, the upper limit is 270 regarding the thyroglobulin. So the NGS, EGFR positive exon 19 deletion, and the PDL1 is 70%. Patient had total thyroidectomy, was carried out, and the mass was about 3.4 centimeter proven metastasis, and patient received radioactive iodine and finished on 1 month ago. I do have a concern actually and we'll come to this on the discussion, as doing total thyroidectomy. This is considered metastatic. It's not double malignancy, but we'll put this in consideration on the discussion of the case. The MRI brain and PET scan showed no detected disease other than the lung lesions. So Dr. Mona from Mansoura University, she is asking how to manage this patient, EGFR positive patient, metastatic to the thyroid. We have only lung lesions, bilateral lung nodules. So what do you see, how to manage? Osimertinib, single agent osimertinib plus chemotherapy, lazertinib, and I'm not sure that you can have it access in Egypt, but we need to put in consideration all the options. Can you please vote? Can you please give us the results, please, Raghav? So the majority go for the osimertinib plus chemotherapy as FLAURA2, and 30% went for osimertinib, lazertinib, about 6%. I think it's fair enough. So Prof. Gilbezo, I think we are sometimes missing and the first thing that for a patient has metastatic to the thyroid, it's considered a site of mets. Do we need to go for total thyroidectomy for this patient and even expose patient to radioactive iodine? Do you agree about this approach, or we just only supposed to be considered as a metastatic disease and we can have a biopsy confirming the pathology and we can go for treatment? Do you think that, and this is a learning element for us and all our colleagues, do we need to go for radical resection for this patient?
I don't think so. The only option would be that there is a compression of the trachea, for example, if we have a really big mass. But even in that case, we can go for radiation therapy in that lesion specifically with a palliative, decompressing objective. Otherwise, I don't think we have to practice what it would be the standard of care for a primary thyroid malignant lesion, right? Which is not the case. If this is truly non-small cell lung cancer metastatic disease in the thyroid, I think we have to treat it as any other patient with bony or liver or whatever disease. So go for primary systemic therapy.
Yeah, I agree. And even they give her radioactive iodine as well. And also my concern as the patient will receive osimertinib, and those patients, they may be susceptible to pneumonitis because of the receiving iodine initial. So Dr. Osama, what do you think that we are supposed to do a resection for this patient, or we can just only have the biopsy and we can start systemic therapy?
Well, I don't see the point of doing total mastectomy for the thyroid metastasis. To be honest with you, the burden of the disease is way beyond. This is not an oligosite of metastasis. So I would have started systemic therapy.
Agree totally.
And I don't really, any of these options are still, present in the ISMO and NCCN guidelines. So you could go, there is no wrong option here, okay? You could start with any systemic therapy you like, but you have to choose the systemic therapy that will give the patient the best chance of disease control and survival.
Yeah, I agree. I agree with our colleagues. The majority go for the osimertinib plus chemotherapy, and 30%, which is a good number, going even for osimertinib, and still 6% can see that lazertinib can be an option as well. So last vote by Dr. Grow. What do you think, Christian?
I was thinking about, this is, again, I would just like go do resection of that mass in the thyroid gland. I would like to understand what's the story there. And my question was, the PD-L1 expression level was 70%. This was taken from the metastasis from the thyroid or from the original lung tumor side?
I'm not sure, but I think that it was mainly the NGS. It's from the
Okay.
lung, and because they have double, they have
Mhm.
two specimen. They have the from the lung initial, and then when they
Mhm.
did the thyroidectomy, they
Okay.
found that it's confirming the pathology, but they didn't repeat the data. This is when they are sending me the case.
The reason I asked, I was just curious because I tried to look that up,
Is there is a
but there is
difference if we do have, because we know that I'm not sure that we do have a difference between the primary site and the
yeah,
metastatic. It's
usually
always
the PD-L1
yeah,
tends
it's
to be
always
higher
better.
in the
Yeah, it's
metastasis.
always yeah, okay.
But the question I ask is just now that PD-L1 expression of 70%, and I tried to look that up from the clinical studies, the crucial studies like FLORA2 or Mariposa or other trials, if we can discriminate in terms of outcome, if we correlate with PD-L1 expression, because in post-hoc analysis and real-world data sets, PD-L1 expression, which is very high, these patients tend to have a poorer outcome.
Yes.
And for me, it's just like rings a bell. If I see a patient with a PD-L1 expression of 70%, I think it's a very heterogeneous tumor. And I tend to give a combination therapy there, but I have no data. At least I couldn't come across any data showing that it was specified for that in these crucial landmark clinical studies. But it was worthwhile to understand. Obviously, this is a tumor that has a different kind of a behavior. So I would just definitely opt for combination therapy there.
It was my perception as well, honestly, Christian, for the cases that the patient with high PD-L1 expression and driver mutation, those patients, they are not doing well comparable to the patient with lower. So
Yes.
this is proven the point. And Dr. Osama, he was presenting his case with PD-L1 90%.
I don't have
And
access to your webinar. I can
yeah,
help
yeah,
if you.
please. Yeah, please go ahead, Dr. Sharif. Thank you very much for joining. Who was talking? Okay. All right. I think, Sharif, do you want to comment or something? Okay. Perfect. I think we going for the third part of the session tonight. We started first with the upfront therapy, and we had a great cases with Dr. Shahina and Dr. Osama and Dr. Dua. Thank you very much for sharing your cases. And we'll go for the second part for the patient who refractory EGFR and going for the second line. And we'll start first with our dearest colleague and dearest friend as well, Dr. Ibrahim Madkhali. He is medical oncology consultant in Jazan, and he is the head of the oncology department there. He will share one of his cases with non-small cell lung cancer EGFR positive patients. Dr. Ibrahim, thank you very much for joining, and the floor is yours.
Thank you, Dr. Murfit, for an excellent organization. I don't know my voice is clear because I have difficulty to display the video.
Your voice is absolutely clear. Thank you very much.
Okay. Just 1 second.
Yes, absolutely. Take your time. We can see your slides.
Okay.
Perfect.
So I'll present one of my patient. It's gonna be straight forward and a classical case.
Can you put it on the presentation mode, please, Dr. Ibrahim?
Okay. Is it presentation mode now to you?
Just click on it.
Yeah. Okay.
Yes, perfect.
So my patient, she's a 63-year-old female. She initially presented to us in June 2022. She's hypertensive and diabetic on regular medication. She presented with back pain and was getting worse. And then she presented to ER with lower limb weakness and muscle power was 3/5. And we have done the MRI, and it showed the destructive lytic lesion at T8 with spinal canal stenosis. We completed her workup. There is CT scan, it showed right lung mass, and there is multiple ipsilateral metastatic lung and pleural nodules and few mediastinal suspicious lymph nodes. Also, bone scan confirmed destructive lesion at T8 vertebral body, and there is also another 2 foci of metastatic deposit at left 8th rib. So the patient underwent for decompression surgery, vertebral fixation by a screw with good alignment, and pathology from the vertebrae showed metastatic adenocarcinoma with focal mucinous component with lung origin. Also, she developed acute pulmonary embolism managed with anticoagulation, developed left hip hematoma with combined service of hematology and surgery and medical. We try to manage the patient. And her molecular profile came as BDL1 expression negative and EGFR19 exon 19 deletion positive. And in July 22 started on osimertinib single agent in addition to bone agent denosumab. And that's based on a FLORA trial. It showed a significant improvement in the BFS and also in OS survival. The interim CT scan, as you can see on the CT scan, there is regression of the mass with the treatment. And there's one slide not here. The patient remained good control on disease when treatment with stable disease, improvement in performance status. All subsequent CT scan revealed the stable disease until November 25. And it showed progressive disease in terms of interval increase. That means after 3 years, interval increase in the size of right lower lobe of the lung mass and new fissural nodules. And also there is increase in interval increase sclerotic lesion. We could not do bone scan because it was out of surface. And after 3 years of a single agent osimertinib, we started second line amivantamab plus chemotherapy, carboplatin, pemetrexed. She tolerated well treatment. I had experience before with amivantamab. My first occasion, my first patient developed all side effects with amivantamab, skin reactions, all toxicity, infusion reactions. This patient, she did very well with the amivantamab and chemotherapy, and you can see the lung mass and fissural mass regress in size with treatment. It was in the right lung around 4.2, regressed to 2.7, 1.9 centimeter. Also the fissural mass also reduced in size, and also there is regression of mediastinal lymph nodes. And as you know, the Mariposa trial they included patients with such progression on first line of osimertinib randomized to standard chemotherapy or chemotherapy carboplatin plus amivantamab, and the trial clearly demonstrated improvement in progression-free survival with hazard ratio 0.48, and also there is trend overall survival, and the objective response was 64% in amivantamab plus chemotherapy arm versus 36%, as well as the BFS was improved with amivantamab plus chemotherapy arm with hazard ratio 0.64, and still in the treatment, and she's gonna have a second assessment in a few coming weeks. This I conclude my case. Thank you.
Thank you very much, Dr. Ibrahim, and thank you for sharing your experience. I think the patient is a typical history of a patient with EGFR receiving osimertinib, and patient was responding almost like 3 years, and then the patient progressed, and she had a good and durable response to this combination. And the good thing also that we get learned to handle the toxicity, and the patient now, she is doing well, and you know how to even expecting and patient education as well. So the question is for such cases, do you always giving the patient the informations or giving the introduction with the side effects as a prophylactic, and so you are avoiding, or it depends on patient one to the other? What do you think?
Yeah, as our colleague demonstrated in previous presentations and based on Paloma trials, the prophylaxis is mandatory. We pre-medicate all patients with for skin toxicity measures and also anticoagulation prophylaxis. And really, those measures help to prevent preemptively those toxicity before happening. So it's, I think now standard of care to start those pre-medications.
Yes. Prof. Christian, what do you think about the sequence and the therapy for this patient?
Was appropriate. I think it's like, we try to figure out what is the escalation, de-escalation strategy for patients with EGFR mutated lung cancer. And I think I like that idea, just like to have the constellation that you add chemo and then amivantamab for that purpose. And again, we stressed that point before, maybe more often we need re-biopsies in patients. More often we should try to understand what is the trend of the progressive disease. So, but overall, I think adding a standard care chemo is still a very good choice in EGFR mutated lung cancer if you have progressive disease.
Yes, I agree totally. Again, thank you very much, Dr. Ibrahim, for sharing your case. We'll go for next speaker and the last case presentation tonight. Dr. Abdurrahman Zard he is a medical oncology consultant in Qatar. He also he will share one of his cases for the patient with Mariposa 2. And thank you, Dr. Abdurrahman, for joining us tonight and sharing your case and the experience. The floor is yours.
Can you see my slides?
Yes, absolutely.
Okay. So thank you very much, Dr. Mervat, for this interesting meeting. Really very extensive and a very good number of candidates. Very impressive. My patient, he's 56-year-old Asian male who presented with a 3-month history of backache and was treated in private center. And initially, he presented in his home country with that backache and, a lot of physiotherapy and thing was going on, but was not investigated until when he exhausted and went to tertiary hospital where they did CT spine and show latex lesion, and a biopsy was taken by the spine surgeon, and it turned to be adenocarcinoma, and they mentioned most likely of lung origin. So patient immediately, as he was working in Qatar, he came to Doha, and he presented to our hospital. We reviewed the scans, and this was some scan showing multiple vertebral lesions. And we reviewed the biopsy material, and it showed that was in February 2024, showed that it is PD-L1 positive 70%. And also ALK negative, and we requested NGS staging workup, PET CT scan, and MRI brain. PET CT scan unfortunately showed that he has right lung lesion, right upper lobe, and you can see on the right hand side the PET CT scan extensive bony metastasis, pelvic, vertebral, and rib lesions, plus mediastinal lymph nodes. This was another view of the PET CT scan. You can see the lesion in the pelvic area, sacral, and also in the ribs. Patient was the PD-L1. This was the PD-L1 report, which came 70%. And we waited and also arranged for him chemotherapy. But meanwhile, we got the NGS report, which was show typical mutation of L858R exon 21 mutation with co-mutation of TP53 with R273C. So this patient initially, because of waiting for NGS, we usually start in a patient, symptomatic patient, chemotherapy first cycle. before the FLORA-2 protocol. So we used to stop the chemotherapy and then consider if it is positive, we give osimertinib. So patient was also after first cycle had some side effect when NGS came after discussion. He preferred not to take chemotherapy after that first dose, preferred to take oral medication. So he was given osimertinib 80 milligram daily. He tolerated well. After a visit within 3 weeks of starting, his bone pain and rib pain improve also because of bone involvement and vertebral metastasis. We did dental clearance for these patients and started on denosumab 120 milligrams subcutaneously. This was the follow-up scan probably just after 4 months, and showed an excellent response to osimertinib. So we continue well manage a very low toxicity profile of osimertinib, and we didn't see any major. So a patient in after 12 months on osimertinib, he started to have again back pain, and we did restaging PET CT scan. And at that point in time, there was reappearance of the tumor at the multiple sites, mainly at the vertebra. And also he had palliative radiation to the spine because for the backache. And so that was the time where we decided now to go to a Mariposa 2 protocol, which is chemo with the amivantamab. So we started him on carbo, pemetrexate, amivantamab. You can see here, and this was in February 2025 when he started to have progression. So February 2024, the disease July got better, and February after 1 year start progressing. You can see the lesion on the most left-hand side PET CT image. Here again, the PET CT showed that in February there was progression of the disease in the spine and the some of the mediastinal lymph node and the primary. Patient received first dose. His weight was 86 kg. So usually we, as per the protocol, we give 1400 milligram above the 80 kg weight, and he received day 1 split dose with the skipper, protocol. 350 milligram on day 1 and day 2, 1050 milligram. This was like the dose administration. I think now people are very much familiar to give for weekly, and then after week 5 onward, every 2 weeks to be continued. And as per skipper, we give them dexamethasone 2 days, 8 milligram BID, and 1 hour before starting diphenhydramine acetaminophen. And we have our own also protocol and guideline in the daycare unit for these patients. Particularly, we have to give infusion in the first hour, 50 ml per hour, then subsequently increase. This is very important because initially we noticed a lot of these reaction, and reaction usually they had reaction in the first few weeks, particularly first day and 2 and second week, and then gradually subsequent infusion, the reactions are much lower. And this is also a slide for dose modification for patients who are not tolerating or due to paronychia or other side effect. We used to reduce the dose by 1 dose, 700 or 1050 milligram, depending on the weight of patient. So patient initially had just mild fusion reaction, but that was mild, managed with some delay. And also we use cocoon protocol, but it was there was a kit available by J&J, but that was missing at that point of time. He didn't receive as a proactive. I think Dr. Osama Halawa, he mentioned proactive treatment is very important in these cases. We have previous experience from the cetuximab treating in head and neck tumors and colorectal. I think proactive make difference. So, but this patient developed this acneiform rash on the face and upper chest, and we advise him to avoid sun and use alcohol-free emollient, protective clothes, and then started him on, we have something called erythromycin, Zanaret lotion, which is erythromycin topical, and sometime clobetasol propionate is also helpful on topical with the tetracycline or minocycline 100 mg BID. Patient also develop another important side effect, which is limiting the management of these cases, is paronychia. Sometimes it's very painful, and this patient develop after 18 to 20 weeks start to have. We tried involve the dermatologist using different creams and antibiotic courses. We also try to modify the dose actually, but patient strongly refuse, actually decline to modify the dose, because he was much worried about the cancer rather than the side effect. He said he can tolerate. This is just a paronychia, the treatment algorithm for patients who have grade 1, 2, and 3. I think most of us familiar. So moisturizing and the nail care of the nail is also very important. Avoid overcutting and thing, because it might, and particularly diabetic patient also, we have to be careful. So this was a follow-up scan after the starting carboplatinum and pemetrexate with amivantamab had excellent response. You can see that the bony lesion, almost the FDG avid activity disappear, with some lesion mediastinal significantly morphologically, and by FDG avidity, SU max was significantly reduced. And here, this just comparison for the initial progression and February and in June, you can see the reduction in the morphologically and to the FDG activity. So patient since March till May 2026, his skin rash was managed. Paronychia didn't improve with the several courses, but he continued the treatment. PET CT scan recently, since February or March 2025 until date May 2026, he was on amivantamab every 2 weeks. And now we decided to go with modified dose. And recently, this month, I did a PET CT scan restaging. The previous one were stable, and now it showed some activity reappearance in the mediastinal lymph node and a lesion at the lung. But the PET CT scan reported mixed response. The bony lesion, still you can see the broad view on the right-hand side of the spine, and the ribs, there is no activity in the bone, but there was. And also, I forget that initially after osimertinib progression, we did liquid biopsy, but it didn't show any additional mutation. It was same L858R mutation. So at this point of time, we are going to discuss, and also a patient who progressed after amivantamab chemotherapy, probably because he received osimertinib in first line. So in third line, I think we had previous couple of cases discussion, and ADC will be the way to go. So we are probably now discussing him next week in our thoracic MDT with our radiation oncology colleague, because if these are a couple of or oligo progression sites, still we can go with targeting with SBRT those area and continuing the effective treatment he has since February 2025. Or the other option is we can still consider docetaxel chemotherapy, which is always available. And we have ADCs as datopotamab deruxtecan has been approved now, even in second line of EGFR, who receive initially amivantamab and lazertinib. And then we have sacituzumab govitecan is another drug coming soon in the management of these cases. So by that, thank you.
Thank you, Dr.
listening.
Abdurrahman. This was, yeah, thank you. Thank you very much. It was a great case and extremely well managed, and I agree totally about your approach. I do have a question from Dr. Zainab from Morocco. She is asking the patient if the patient receive chemotherapy, what to do for the subsequent line. I think she meant that if you started, because you started with osimertinib, it was an easy decision to go for the second line with the Mariposa 2, and now it's a standard of care. But because most of the us now doing the Flora 2, and so and so if it will be short period and the patient progress, what to do as the backbone for the chemotherapy. And the question to you and also Prof. Grow regarding such case, because this is what we are seeing now in the clinic. So go ahead, Dr. Abdurrahman, what do you do?
Yeah, thank you very much. This is now very interesting area, because Flora 2 we give 4 cycle with the carbopemetrexate, and then we drop carbo and continue pemetrexate. But also we have I have patient who receive maximum for 1 year pemetrexate, because we have to be very careful. They develop renal toxicity, and it is you may lose the kidney. So you have whenever you see there is patient tolerance, we usually stop and just maintain on osimertinib. So in case if this patient has chemo-free interval is more than 6 months, yes, at that point of time, I think Mariposa 2 is still justified to give again re-challenge of chemo with amivantamab. But in case while patient is on chemotherapy and osimertinib and he start progressing symptomatic multiple, if he has still oligoprogression, because this is very tricky disease, unlike other solid tumors, the EGFR-driven tumors have different clone. And Professor Ignacio or Professor Christian Grohe, he can tell us these tumor behaving sometimes, some area, like I have seen my patient with mixed response and bone disease is still well controlled, but appearing in the mediastinal and other. Sometimes we want to have a biopsy, but unfortunately, patient get fed up of these repeating biopsies, and also liquid biopsy doing Signatera or other is quite expensive and challenging and with the insurance or the facility. So I think, if we can do still loco-ablative, always asymptomatic or minimally symptomatic patient, and PET CT scan is saying progressing, I think we need to stick to them. Otherwise, we can consider then amivantamab. I'm not sure, but I think in that situation, datopotamab will be the answer as per the guidelines. But again, in reality, we can give these patients also docetaxel chemotherapy. And I have given some patient docetaxel and they still responded. Is old drug, but still gold.
Yes. So, Prof. Grow, if we do have given the patient Flora 2 and the patient was under maintenance and patient progressed, what the chemotherapy backbone we have to go?
So basically, if this is, as you just pointed out, is oligometastatic disease, then we have to consider this North Star protocol we just heard about last year at ESMO and control disease burden. If this is multilocular disease and fast progressive disease, then we have to switch to a more effective drug, such as amivantamab. I don't know if anybody still uses ABVD, the IMpower 150 protocol. In some patients that did work actually to control disease burden in our patients in an old-fashioned way. In terms of, and coming back to the idea of the ADCs, we have now seen data with SAC-TMT, the OptiTrop data. These seem to be more promising than the Dato-DXd data, but we should wait for that. I would rather go in terms of understanding for these patients, if it has progressive disease, multi-progressive disease, you still can use ABVD, IMpower 150, or you can switch to amivantamab.
Thank you, Dr. Abdulrahman, for sharing your case. I'm sorry, we are a little bit lag behind our schedule. We'll go for our keynote lecture tonight, Prof. It's my pleasure to introduce Prof. Ignacio Gilbazo. He is head of lung cancer program and Department of Oncology in UCV. University in Spain. He will share one of his cases and also will give us update in the management of metastatic non-small cell EGFR positive patient. Prof. Ignacio, thank you very much for joining, and the floor is yours.
Thanks very much, Dr. Bermat, for the kind invitation. Once again, I'm really glad to be part of this tumor board meeting. So with no further ado, I will start by presenting a case very similar probably to many of the cases we've been hearing tonight. So this is a 51-year-old female, married, 3 kids, very active, I would say, professional as a lawyer in an important multinational firm in Spain.
Prof. Ignacio,
yes.
Kindly, we didn't see your slides. Can you please share?
Yes, I was sharing them. I'm so sorry. Let's see.
No worries, that's fine.
Okay. Do you see them now?
Not really.
So it says to me that it is shared, and
yes,
the only option I have is to.
Yeah, we can see it now.
Okay.
Yeah.
All right.
Go
Sorry
ahead.
about that.
No worries.
So,
okay.
As I said, this is a young female, very active professionally and from the family point of view. No relevant past medical history, light smoker, former smoker, 10 pack per year, and a family history of lung cancer. We've considered this in a previous talk. And she presents with chest pain, grade 1 dyspnea, weight loss, 8 kilograms in 5 months, and no neurological symptoms. She was finally diagnosed with stage 4B lung cancer with lung, pleural, bone, lymph nodes, and brain involvement. These are some of the images that you can see with the brain involvement, with the large left upper lobe mass, and the pleural involvement too. So we went for tissue as well as liquid biopsy. This is a liquid biopsy result showing not only EGFR common exon 19 deletion mutation, but also EGFR, BRAF, and CDK6 amplification, as well as a mutation, concurrent mutation in TP53 that we have talked about this before. So the first question would be, should we go for a combination or monotherapy? So FLAURA versus FLAURA2 or Mariposa, or may we consider first or second generation EGFR TKI, or even just platinum doublet chemotherapy. So in this case, and I think we've talked about this all this night, probably we are considering combination therapy as the preferred choice, which is currently the standard. And in this particular case, I decided to go for Mariposa treatment. So this is something that has also been shown before with the really relevant prophylactic and prevention strategies we should use and implement from the very beginning or even before starting treatment for these patients. So remember, for IV infusions, we should go for oral 8 milligram dexamethasone 2 days before, the day before, and the day of treatment. In this case, this patient was treated with subcutaneous formulation. And just remember how important it is to apply those dermatologic prophylactic regimen in the COON trial, because we can reduce grade 2 or higher dermatologic adverse events by 50%. So this is how the patient actually evolved, with a very nice initial partial response that was maintained over time. And currently the patient is also in the brain. And the patient is currently 24 months after treatment initiation, 2 years after. She just experienced grade 1 peripheral edema due to MET inhibition, grade 1 asthenia, grade 1 skin rash, and grade 1 paronychia, not needing dose reductions, and no gastrointestinal toxicity at all. So we might consider what will be next when this patient eventually progresses, and that is something that we have also considered before in other talks. So what are the current limitations of monotherapy as in FLAURA trial with osimertinib? Well, we know, and this is something that has been already exposed, we know osimertinib is much better than first generation EGFR TKIs in the FLAURA trial. However, numerically, we see that is only around less than 9 months benefit or 7 months benefit in comparison. At the same time, we know that sometimes some patients may have a more aggressive behavior of the disease with rapid or really short-term benefit from osimertinib alone, such as in this case. And these patients tend to have a disease that grows rapidly, and we might not have very good chances for treating these patients in a second line, and many of them never make it to the second line. So what are the three main limitations of osimertinib alone? So first, I would say we have a significant proportion of early progressors, as you can see in the left-hand side of the slide. Secondly, we have only less than 1/3 of patients that are still on treatment with osimertinib 3 years or later. And finally, we have really few long-term responders, around 10% 5-year responders. So this means that we really need a paradigm change. And how could we change to be better in that sense? Well, probably we're moving from less is more to more is better. And for that more, we have to consider the two standard regimens in first line for EGFR mutant non-small cell lung cancer patients. First is the FLAURA2 trial. We have heard about this. Just two very brief comments regarding this clinical trial. First would be that we are not considering brain metastasis as a stratification factor, and this is important. Secondly, we are not monitoring brain involvement over time. And these are two important differences as we compare with Mariposa trial. And the third would be the total number of patients that were accrued or enrolled in this clinical trial. Regarding the clinical characteristics of the patients, I want to highlight the big number of patients with CNS metastasis. And this is probably very well noting that a brain MRI or CT scan of the brain was mandatory at the beginning for recruitment of these patients. So when we actually screen for brain metastasis, we find a high number of patients. This was clearly a positive clinical trial with the main objective that was median progression-free survival benefit as compared to osimertinib alone, with nearly 40% reduction in the progression risk. If we look at the final overall survival analysis, we see that it is also clearly beneficial in terms of overall survival as compared to osimertinib, and osimertinib plus chemo render a really interesting result with a hazard ratio of 0.77. That was not only numerically, but also statistically significant, around 9.9 months benefit comparing Osi chemo versus Osi mono. If we look at the different subgroup analysis for overall survival, very similar results. Most of the groups were benefiting from the combination treatment, and also that was the case for CNS overall response rate that was in favor of the combination strategy. But not only that, also CNS progression-free survival was in favor of the combination, specifically for the CNS available for response set, not for the full analysis set. When we talk about tolerability profile, of course, as always, when we combine more than one option of treatment, when we go for combination strategies, we are taking the risk and we are paying the price of a higher toxicity profile. This is also the case for the FLAURA2 trial, with a significant proportion of patients with grade 2, grade 3 or higher hematological toxicity, neutropenia, neutrophil count decrease, also ALT increase. And of course, we also have diarrhea and rash, etc., which is also related to the inhibition of EGFR. So interestingly enough, we have to see that the Osi median treatment exposure was 30.5 months, but pemetrexed was less than 9 months exposure. And platinum, of course, only 4 cycles, so 2.8 months. So this is also something to bear in mind. What I mean by this is that we are flying with 2 engines from the very beginning, chemotherapy plus osimertinib, but very soon after we are starting to fly only with 1 engine. And this is important in order to see what we can expect in the longer range. The other might be better strategy option would be the Mariposa trial, combining amivantamab plus lazertinib, as we have mentioned before. Again, in this particular clinical trial, Mariposa trial, we were considering brain history, brain metastasis history as an stratification factor. So that means that when we look at the results of patients with or without brain metastasis, we are able to make final conclusions because it was as part of the stratification factor. These patients were actually monitored throughout the clinical trial for CNS improvement or progression. And the total number of patients that were included is more than 1,000, so nearly twice more as in FLAURA2 trial. Again, this is also a clearly positive PFS as primary endpoint clinical trial, has a ratio 0.7, and we have around 9-month improvement, 7-month improvement in PFS. If we look at the overall survival curve, we know that we don't have the sufficient maturity of the curve yet, so we don't have final results, and actually the AMI laser arm has not reached the median, so we don't have that data. However, we are expecting to see a more than 12-month improvement benefit as compared to osimertinib alone. And very significantly, I would like to highlight the tail of the curve, how it tends to separate more and more as the treatment goes by. Again, similarly for all OS, we have a very similar benefit for all different subgroups. And that is also important for CNS positive patients when it comes to intracranial PFS, but also duration of intracranial response. And again, this is something that we can actually have as a very clear conclusion because brain metastases were part of the stratification factors. We also have heard about the high-risk factors or features in these previous talks this night, and we know that brain mets, liver mets, TP53 mutations, and detectable ctDNA are very specifically considered worse prognosis factors. And when we look at the different comparisons between OSI monotherapy and amilaser in the Mariposa clinical trial, we see that there is a clear benefit for all these subgroups of higher risk patients. When it comes to tolerability profile, again, when we combine more than one treatment, we are exposed to higher toxicity. In this case, we have EGFR inhibition related toxicities such as paranuclear rash, not importantly diarrhea in this case, and at the same time we have the MET inhibition related toxicities such as hypoalbuminemia and peripheral edema. Most importantly, I would like to highlight that all these alterations, all these adverse events are highly predominant in the first 4 months of treatment. And this goes really down when the treatment goes by. And we are minimizing this. Of course, also using the different strategies that we currently have in place for minimizing thromboembolic events, for example, or infusion-related reactions or dermatological toxicities, as we have learned tonight. So this is just a quick reminder for preventing infusion-related reactions with oral dexamethasone 2 days before, the day before, and 1 hour before the treatment. Very recently this year, about 3-4 weeks ago at ASCO this year, it was presented the Copernicus trial. This is, let's say, a Mariposa trial, but implementing from the very beginning all the different prevention strategies for minimizing toxicities. And this is very important because, as I always say, probably Mariposa trial is the first trial ever that the clinical results or the clinical outcomes of those patients within the clinical trial, the pivotal trial, are probably expected to be lower than in real practice, because we are using all these new measures to provide a better quality of life and to provide a more maintained and sustained treatment for patients, because we are lowering down significantly all the toxicities. So how we can decide? This is something we have also touched on later or before. First, patient preference, ECOG, and comorbidities. These are important. Remember, renal impairment, for example, might not be a good candidate for, let's say, chemotherapy-based regimens. Of course, tumor characteristics such as the sites of metastasis, concurrent mutations, or even the EGFR subtype, but also side effect profile, intensity of monitoring, later line options, and finally, accessibility problems such as reimbursement policies, chair time, or drug availability. In order to make a decision, I also invite you to consider overall response rate and resistance and mechanisms of action. So first, if we look at the left-hand side of the slide, how deep are the responses that we actually get with the different protocols, FLARA, FLARA2, or Mariposa? Look at the number of, or the proportion of patients with complete responses in the AMI-LASER clinical trial, which is significantly higher than OSI chemo or OSI alone. But also, we have learned about the different mechanisms of resistance, how MET is significantly lowered down as a mechanism of resistance when we use amilaser as opposed to osimertinib, but also secondary EGFR resistance mutations lower down significantly when we use combination strategies using amivantamab. Of course, we know that amilaser is also using another mechanism of action, which is based on the trogocytosis and also activating the immune system. And this might be also relevant for the tail of the curve. This is just something that we have mentioned before. We know those patients with MET amplification on osimertinib tend to early discontinue treatment. And this is something we are impairing, or we are preventing to happen when we use AMI laser. And finally, for making that decision, overall survival curves also should be taken into account. And we have three aspects I would like to consider. First, what is the shape of the curve? And we have the typical banana shape of the curve for FLAURA, but also we have it for FLAURA2, as you will see in a minute. But also, look at when those curves actually start to separate is after month number 15, so really later on. And then we have still that banana shape, so that means they start to separate, but soon after they merge again back. If we look at Mariposa, we see that those curves are separating from around month 11, not 15, and we are not having that banana shape of the curve. The tail of the curve still separates on and on. And finally, as I mentioned before, we are expecting, although we do not have the final results yet, probably later this year, an improvement of more than 12 months for AMI laser in comparison with OSI chemo for OS. This makes laser AMI as a preferred option within those category 1 combination or treatments in first line. But more importantly, if we look at the ESMO magnitude of clinical benefit scale, if we look for Mariposa and laser AMI, we have a score 4, which is substantial benefit. Look at FLAURA2. This is a score 3, so it doesn't reach that substantial benefit score according to the ESMO MCBS. And finally, when considering sequencing, of course, we have to consider what has been our first choice, and then what other options are possible. But we should stratify risk and consider all the different aspects also for making a good decision for first line, but also for second or third line. However, consider always giving your best shot first and not keeping for second line, because many patients might not make it to the second line. In conclusion, non-small cell lung cancer treatment has dramatically changed over the last 20 years, and specifically for EGFR mutant patients. First line osimertinib has been the standard for many years, but currently we have combination strategies, 2 different options that are the new standard treatment. OSI first line monotherapy should be restricted only to frail elderly patients, individuals with comorbidities, or those not willing to present a potentially higher toxicity. And although FLAURA2 and Mariposa combos show similar characteristics, there are some differences, as I pointed out, and we have to consider those OS curves, maturity, and shapes that I mentioned before. A thorough discussion, finally, with the patient about all these factors mandatory for making a good individualized therapeutic decision. Thank you very much.
Thank you, Prof. Gelbez. That was excellent talk, and thank you for sharing your case and your experience as well. Because of the sake of time, will take one question, and the question is from the audience. They're asking, is there any predictive factors for tumor response with AMI laser, or predictive for the toxicity?
That's a very good question. I don't think we have good biomarkers for deciding so far what are the let's say the perfect characteristics for AMI laser. I don't think we have that yet. Of course, we know that higher burden of disease. We know that concurrent mutations such as TP53, brain, liver mets, other ctDNA still present in blood. All those factors might be good indicators of a need for combination, and probably AMI laser would be preferred in those cases. But we don't have a final perfect biomarker. of course, we should consider all these along with the patient and the families, and I think this is also important.
Perfect. Again, thank you very much. I think we will go. I'm totally sorry that we are lag behind our schedule regarding the time, but actually the discussion and the cases was very interesting, and also the talks. And with that, I would go for the last part of the session tonight, which is the Light Symposium. And the meeting tonight is sponsored by Johnson & Johnson, and so we'll go for Light Symposium, and it will be shared by our dearest colleague and friend, Dr. Abdullah Al-Twigri. Dr. Abdullah Al-Twigri is known for everybody, medical oncology consultant in King Fahd Medical City in Riyadh, and he is the head of, and his interest is lung and breast. He will chairing the Light Symposium. Thank you very much, Dr. Abdullah, for joining tonight, and the floor is yours. My apology for the late and the delay. Thank you.
Thank you so much, Dr. Mirfat, for I really enjoyed the discussion, and thank you so much for such interesting discussions. And I really thanks Prof. Gilbazio and all the panel for such interactive discussion. So I do agree. I think now we can move to the Satellite Symposium supported by J&J. I would like to introduce Dr. Sharif Kullab. Dr. Sharif Kullab is medical oncologist at King Saud University Medical City in Riyadh. He will touch base on the dual impact of amivantamab in the first-line setting, and how to maximize disease control and prioritize also patient well-being. Dr. Sharif, I will leave the mic to you.
Yes. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you, Dr. Abdullah. And thank you also, Dr. Mirfat, for the very nice organization and the nice meeting with interesting discussion with the different colleagues. My thanks also for all Johnson company for giving me this opportunity to participate and to be with you today, talking about how to maximize the disease control while we are prioritizing the patient well-being, looking at the side effects, and the best outcomes for our patient. As you know, for a long time, we used to treat our patients before the era of third line, fourth line anti-EGFR based medication and the new bispecific antibody. We used to treat our patient with a doublet of chemotherapy based on platinum-based regimen, as you know. Different regimen have been tried and used, as you know, and what we learned from our old or very old experience is that whatever the regimen we are using with chemotherapy, doublet chemotherapy, the response rate is not exceeding 30%, and the median overall survival of our patient was not exceeding 8 months. These are very important bottom parameters that we need to rely on whenever we want to look at the different patient outcomes in the different presented trials, FLORA, FLORA2, and in Mariposa. As you know, the FLORA has become as a standard of care for a quite long time, more than 5 to 8 years roughly, until we started to intensify the regimen for our patient by using in FLORA2 chemotherapy and osimertinib. We have seen very clearly from the presentations tonight that by using FLORA2 regimen, chemotherapy plus osimertinib, we could improve the progression-free survival for our patients from 16 months to 25 months, delta benefit of around 9 months. And if you look to the right side of this slide, you can see on the upper side of this slide, the patient who do have a brain metastasis, the magnitude of benefit by using a FLORA2 regimen is higher compared to patients who do not have a brain metastasis on the bottom side of this slide, with the hazard ratio respectively 0.47 for patient with a brain metastasis and 0.75 for patient without brain metastasis, giving us a signal about the benefit of this regimen in patient with a brain metastasis and mainly in patient with a brain metastasis. As we have seen, this improvement of patient outcomes in terms of progression-free survival by delta 9 months has been translated by almost delta 10 months in terms of overall survival. And the median overall survival of our patient is now reaching 47 months versus 37 months when we are treating them with osimertinib alone. We have seen also the nice presentation from Dr. Ignacio about Mariposa trial. Quick reminder, Mariposa trial was a phase 3 trial, randomized. Huge number of patients, more than 1,000 patients have been randomized in this trial. EGFR positive for the most common mutation, I mean mutation 19 and the 21. As you know, these two mutations represent more than 85% of EGFR mutation in EGFR positive non-small cell lung cancer at metastatic setting. Patients were randomized in 2 to 1 patient to receive either a combination of lazertinib as fourth generation anti-EGFR in association with amivantamab as based bispecific antibody targeting the MET mutation or amplification. On the second arm, we have the common standard with osimertinib, the FLORA regimen, and the third arm is lazertinib. What has been reported is the comparison between the combination, as you know, and the osimertinib, Amilazi versus osimertinib. And the primary endpoint in this trial was the progression-free survival, and the other parameters were put as a secondary endpoint. And as you know, the patients were stratified according to the high-risk group of patients defined in this trial by the presence of brain metastasis, liver metastasis, and the co-mutation by harboring a TP53 mutation or by detecting an EGFR mutation at the follow-up in the circulating, at the baseline in the circulating DNA, but also the clearance of the EGFR mutation. We have seen in the patient proportion that there was a harmony among the different groups, but what is important to notify here is that at least 40% of patients in this trial were having a brain metastasis, conferring a high risk profile of patients in this trial. On the other hand, as it was expected, we had 60% of patients who were having exon 19 mutation and 40% with exon 21 mutation. We have seen with Amilazi, this trial was positive as it achieved its primary endpoint with significant improvement of progression-free survival in favor of using the combination of Amilazi versus osimertinib alone. The delta benefit is of almost 7 months, as we have seen a clear separation of the curve, and the median PFS is reaching now 23-24 months with a hazard ratio of around 0.70. If we look to the patients with or without brain metastasis on the right side of this slide, we can see that this benefit in terms of PFS has been observed with the same magnitude of benefit almost in both group of patients, in patient with a brain metastasis in the upper side with a hazard ratio of 0.69, but also in patient without a brain metastasis, as you can see in the bottom side, with a hazard ratio of around 0.69. This benefit has been observed in the different patient subgroups, and especially in the patients who do have a high risk profile as defined in this trial per stratification. I mean the patient with the brain metastasis, the patient with liver metastasis, and the patient with detectable baseline DNA, circulating DNA in the NGS, and the patient with complex mutation as well, and the patient who are not clearing their EGFR mutation by the circulating DNA test. It's important to notify that in Mariposa study, almost 90% of patients would have at least one high-risk feature profile. And as you can see, this benefit was not crossing the one hazard ratio boundary, and it has been limited in favor for patients in the hazard ratio range, I mean, for all these patients with high risk profile, again, giving us a signal about the importance of benefit that we could obtain by using this regimen in a patient with high risk profile. As you know, and as you have seen, the median overall survival was not reached, but we have a significant improvement with a 25% reduction in the risk of death by using the combination of Amilazi, and the combination arm is showing, as mentioned, a significant improvement compared to the osimertinib arm that has a median overall survival by 36.7 months. When we don't have median overall survival, usually we look to other patient outcomes in order to give us a better signal about the patient outcomes. And in this term, we are looking to the second progression-free survival. As you know, second progression-free survival is defined by the progression after the second line of treatment. And this is giving us a result of the median PFS1, median PFS2, and the interval of time between the end of PFS1 and the starting of PFS2. What we have observed in this trial, as you have seen today, that there was a significant and clear improvement of second progression-free survival in favor of using the combination with a median second PFS passing from 32 to 42 months, again, with a delta benefit of around 10 months. This is giving us indirect signal about the median overall survival that could be observed later on when we have the updated results from Mariposa, which might exceed the 44, 45, 47 months at least. When we look to the overall response rate, as mentioned, with chemotherapy, it was not exceeding 30% roughly. But when we look to the combination of amilazine versus osimertinib, we don't have the impression that there is a clear improvement of the overall response rate. It was almost 86 versus 85. But what is important to look at in this term is the duration of response, which was increased by at least 8 to 9 months by using the combination of amilazine versus osimertinib alone, as we are passing from almost 16, 17 months up to 25, 26 months. And this gives us an information about the sustainability of benefit that the patient could obtain when we look to the duration of response rather than looking only on the overall response rate. Here it's important to look at the acquired resistant mutation for patients who are treated with osimertinib on the left side and the patients who are treated with the combination amilazine on the right side of this slide. Here, each line or each row represents a type of or mechanism of a mutation, and each column represents a patient. If you look to the patients who are treated with osimertinib, we have the impression that there is a variety of mechanism of resistance that the patient develop when they are treated with osimertinib. On the other side, if you look to the patient who are treated with the combination, the number of mechanism of resistance is less and very concise and limited. What we could understand from this slide when we look to the acquired resistant mutation, that the use of osimertinib give a bad chance for patient alone to have more and diversity of mechanism of resistance to the treatment compared to patients who are treated with the combination and who would have a less number of mutation and a very confined and concise number of resistant mutation. If we look to the complex resistance mutation, and here the complex resistant mutation are the resistant mutation for at least more than one, I mean 2 mutations or more. If we look to the patients who are treated with osimertinib compared to patients who are treated with the combination on the right side, the dark circle plot here represent the patients. And we can see as their number represented that the percentage of patients who are treated with osimertinib is 42%, who do have, complex resistant mutation, and almost the percentage of patients who would have complex resistant mutation in the combination treatment arm is 27%, almost the half of the percentage of patients when they are treated with osimertinib alone. Again, here, if we look on the upper side, for the patients who are treated with osimertinib, again, for the detected EGFR driver mutation, and the dark color at the beginning and on the clear color is the patient after being exposed to osimertinib, we can see how there was a decrease in the most common mutation. On the other side, on the lower side of this slide, we can see that there is more clear and significant decrease in the resistant mutations when it comes to EGFR resistant mutation for patients who are treated with the EGFR mutation, regardless of the type of mutation, EGFR 19 or 21. As you know, the most important resistant mutation are the MET mutation and the secondary EGFR mutation. And we have seen today that the use of combination of amilazine is by the use of this combination, we can decrease these 2 mutations by 5 and 4 times respectively. And we look when we look to the other non-specific mutation, we don't have the impression that there is a clear difference between these two regimens. It is important to look at the side effect because at the first presentation of the side effect, as mentioned today by Dr. Ignacio, in the NICE talk, we have different profile of toxicity. Besides some toxicity related to the use of osimertinib, lazertinib as anti-EGFR-based medication, and some side effect related to the use of MET-based anti-medication, I mean the amivantamab, but also we had DVT, VTE, in almost 40% of the patient, and we have some immediate reaction by using the IV amivantamab. These side effects have been presented very nicely in terms of comparison, but what is important to look at when we look at these side effects are two things, in my opinion. Number one, before using the prophylaxis measures, do these side effects affect the patient quality of life? Actually, when we look to the reported patient outcomes for the quality of life and the different scores that have been used, we have seen that the use of combination amivantamab lazertinib compared to osimertinib did not show a meaningful change from the baseline and at any time on the treatment. And that was an important message to keep in mind if we consider the side effect profile of the patient. The second thing is the time of or the incidence of this side effect. We observe that the majority of these side effects, if they occur, they are occurring at the first 4 months. But after that, we don't have a significant improvement and significant observation of these side effects after 4 months. A direct message here from this slide is to look to try to manage the side effect, especially in the first 4 months. And after that, we are reassured about the significant decrease of the occurrence of these side effects. As presented, we have some trials that have been developed in order to improve the patient outcomes. I will start by 3 major trials. The first one is the COCON trial. Basically, in COCON trial, patients who are treated with IV amivantamab plus lazertinib were treated with some skin precaution on the same time. In this trial, we have used the oral doxycycline, but also the chlorhexidine and the ceramide-based moisture application on the extremity, compared the standard of care without using this specific medication. Primary endpoint was to look at the incidence of a grade 2 and more. We have seen that the grade 2 and more were exceeding 70% in the amivantamab IV plus lazertinib trial, the Mariposa-1 trial, I mean. But when we look to the COCON results and to look at the results about the side effect, we observed that there is at least 50% decrease or 2 times reduction in grade 2 or more for all the side effect, and especially for grade 3 and more. Again, there is 2 times less side effect when we are using these very simple local application precautions and also oral antibiotic with simple doxycycline 100 milligram. Another trial was the SKIPPER phase 2 trial, in which we have used different oral or IV medication, mainly the corticotherapy. As you know, it is very common for us to use the corticotherapy as a pre-medication, and we started to apply this for patients treated with non-small cell lung cancer whenever we are offering them Alimta or taxane-based regimen, either 2 days before starting the treatment or the same day and the next days of the treatment. What we have observed in this trial, when we are using a dexamethasone with 8 milligram, I mean 4 milligram BID, starting 2 days before and the 1 day before and the day of the chemotherapy, we could decrease by 3 times the different side effects related to the treatment regimen, and that was significant by using a very simple method or medication like the dexamethasone. It's not a very high because it's mentioned in this trial that some patients could not tolerate the corticotherapy, but in my opinion, in our clinical practice, we are using this dose and even more when we are using other medication. Another important trial, which was a phase 3, presented the Paloma 3 trial in which we have compared the IV versus the subcutaneous pathway of amivantamab when it's combined to lazertinib. It was not a superiority trial, but in this trial there was 2 primary endpoints in order to show the non-inferiority of using the subcutaneous versus the IV. And we looked at the safety profile and the other secondary endpoints in this trial. What we could observe again in this trial by using the IV-based amivantamab, again, we have of the same range, a side effect of around 60 to 70%. But when we are using the subcutaneous pathway, we could decrease all side effect profile by at least 5 times. We are passing from 66% to 13% roughly, without affecting the efficacy, which was confirmed to be non-inferior by using the subcutaneous versus the IV pathway. And when we look to the patient who have used or did not use the anticoagulation in this trial, we had the impression that there was a significant decrease by at least 50%, I mean 2 times, of the VTE for the whole population, for the population who have used prophylactic anticoagulation, but also for patients who did not even use prophylaxis anticoagulation. So for the whole population, the subcutaneous pathway could decrease significantly the incidence of VTE in this trial. And what was important also to look at this trial is when we are using the subcutaneous pathway, we are decreasing significantly the time that our patient passing in the chemo unit to 5 minutes versus 3 to 4 hours when we are using the IV combination. I think today we have seen very clearly the different recommendations or the different choices that we do have in our hands and that we can offer to our patients. What is important to remember always is that the combination or the intensification-based regimen is better than the osimertinib alone, as this has been translated by better outcomes, especially in terms of overall survival. I have just a strong message to give to you that when you look to the different trials that have used different EGFR, anti-EGFR generation, first, second, or third generation, but also the combination as in FLAURA2, we can estimate that we are losing up to 40% from the first line on passing to the second line. We are losing up to 40% of our patients who are not offered a second line treatment. The message here is that we need to optimize the treatment of our patients since the first line treatment in order not to lose the possibility or the opportunity to give them a better treatment later on. If we look to Mariposa 1 trial again, the percentage of patients who could pass from the first line to the second line was respectively in both arms roughly 75%. We have lost only 25% compared to 40-50% roughly in FLAURA2 trial, where we have treated our patients by chemotherapy plus osimertinib and osimertinib alone in the treatment and comparative arm. Our choice of treatment need to be based on the patient outcomes, but also in the different criteria, looking at toxicity, drug availability, drug cost, but also, as mentioned and emphasized on today, we need to involve our patient and patient family in discussion about this, the side effect profile, the treatment compliance issues, and the different patient outcomes when we are using the different choice of treatment at the setting. With this, I reach the end of my talk. Thank you for your attention.
Thank you so much, Dr. Sharif. So before I hand over to Dr. Merfat, maybe we'll go with this question. You nicely discussed the resistant mechanism, and one point I find is very interesting is whether BFS2, which I think is not just a clinical endpoint, but also it might be also a reflection of the resistant biology. Could the BFS2 with lazertinib being partially explained by the different resistance pattern that has been seen with progression to lazertinib compared to osimertinib? You have shown that the progression or the resistance is seem to be less molecularly complex, more probably could make it more sensitive to subsequent, and this is why we see BFS2. Could you think this way, or could be another explanation?
Yeah. Thank you, Dr. Abdullah. To be honest with you, as far as we don't have the median value for the overall survival, this is the reason we rely on other parameter like the second progression-free survival. And in my opinion, which was also important to look at, and that has been looked at, is not only the second line progression-free survival, but the progression-free survival, between the PFS1 and the PFS2, there is a lapse of time where some patients will continue on the treatment and there is a delay of changing the treatment. What was important to look at is not only the second progression-free survival, but only the second line progression-free survival. I mean, only the PFS, the second part of the PFS2. What does that mean? That means if there is a benefit of using the combination of amylase in the first line, is there a sustainability of this benefit when we are using any other second line treatment later on? Actually, when we look to this benefit in Mariposa 1, if I remember well, the second line progression-free survival was 4 versus 7.5 months roughly, and the hazard ratio was of around 0.65. I mean, again, 35% reduction in the risk of progression or death when we are looking only to the second line progression-free survival. The message here is the benefit that we could obtain in the first line by using the combination is sustained and translated or reflected on the second line treatment, regardless of the type of second line treatment we are using after this combination. Maybe the reason behind that, because we started to affect or to work on the resistant mutations since day one. I mean the MET mutation mainly. And in my opinion, this is one of the major beauty or positive side of using the amivantamab-based medications since the first line setting.
Okay, thank you so much, Dr. Sharif. I will hand over now to Dr. Merfat to conclude.
Thank you very much, Dr. Abdullah, for excellent moderation, and thank you, Dr. Sharif, for excellent talk and the overview. It was fantastic to have you both tonight. I would like to extend my thanks to all our faculty tonight, Dr. Osama and Dr. Abdurrahman and Dr. Dua and Dr. Ibrahim Madkhali. Thank you very much for joining, and I would like to extend my thanks to Prof. Galbazo and Prof. Grow for joining us tonight, enriching our discussion and give us your experience and the input as well. I would like to thank all our attendees and thank you. It's almost more than 800 who's still keeping with us. Thank you very much for attending and your valuable questions, and my apology that I couldn't respond to all the questions because of the time frame. And finally, I would like to thank J&J for sponsoring tonight and sponsoring our scientific events. And last but not least, our organizing team. I would like to thank you all, and good night, and thank you for joining, and see you next episode next month, inshallah. Thank you very much, and have a good night.
Thank you very much. Thank you, everyone. Thank you.
Thank you.
Thank you. Bye-bye.
دكتورة ميرفت يعطيك ألف عافية.
شكرا دكتورة ميرفت. شكرا.
Thank you, Prof.
As
Thank you
always.
for joining. Thank you.